So now we are going to discuss insomnia. So what is insomnia, types, okay, and what is the treatment? So that is the focus of our today's lecture. To first coming down to the definition of the insomnia. Basically, we can say it is the dissatisfaction with the sleep quality. Dissatisfaction with the sleep quality, but not only the quality, it can be quantity also, the duration or the kind of sleep I'm having. And sometimes the persons will say, actually, have a difficulty in falling asleep. That means initial period of the night, I'm having the difficulty. You can say there's a problem in the induction of the sleep, difficulty falling in asleep. But later on, I'm okay. Once I am asleep, then it is okay. But some person says, there is no problem in actually induction. I go to sleep normally, but I'm not that much able to maintain the sleep. There are frequent night awakenings, maybe 1 o'clock, 2 o'clock, 3 o'clock. It depends on the person. Okay, and once I awake, then I'm not able to sleep. Okay, so that means the later half of the life. Sorry, sleep. Not. So the maintenance. So two problems are there: induction and maintenance. So obviously that I told maintenance, early morning awakenings and not able to return to the sleep. Sometimes this is the problem. We are dividing into two parts because therapy can be different. Some drugs are for the induction, some are for the maintenance, some drugs are for both. Okay. So as per the definition of the insomnia, we can say insomnia if it occurs at least for 3 nights in a week, at least 3 nights in a week, and it should continue for at least 3 months. Then we say it is a insomnia. Okay, but that doesn't mean we cannot give drug before 3 months. We can give before 3 months, but as per the definition, I'm saying it is defined when it is having more than 3 months. Okay, so that can be transit insomnia if it is for a shorter period of time. And it should not be substance related. It should not be because of the alcoholic use or any other use. So it is not called as insomnia. Insomnia, typical insomnia, the typical definition, it is not due to substance use. Substance here is the drug of abuse. Relatively more common in women, relatively more common, and in elderly. These are two major persons, women and elderly, particularly elderly. They are one of the major populations coming in this disease. Now, one slide on the neurotransmitters and the hormones that are involved in sleep. Okay, one of the major neurotransmitter is the 5-HT. 5-HT, the important neurotransmitter in the sleep, and hormone melatonin is one of the important hormone. And what is the source of melatonin? Is the pineal gland. And this is the amino acid. Tryptophan is an amino acid. And what does it do? It is a precursor of 5-HT and melatonin. It means tryptophan can lead to formation of melatonin, which is a hormone. Tryptophan can lead to the formation of 5-HT, which is a neurotransmitter. So obviously you can say tryptophan can be one of the good amino acid for the sleep purposes. Tryptophan. Now, if we talk about the brain system, which brain part is involved in sleep and wakefulness? So you will see it is the reticular activating system. This part of the brain, reticular activating system. And where it is present in the brain stem portion, lower portion of the brain stem. And this is helpful in maintaining wakefulness and sleep, reticular activating system. Now, this slide will show what are the different types of insomnia, not in detail, but generally, little bit. Most of the insomnia, we can say insomnia with no any other disease, without any other disease, without comorbidity. And if we talk from a therapeutic point of view, this kind of insomnia responds in a best manner. But there is insomnia with comorbidity or some diseases or some drugs, these kind of, because these drugs are given for a long period of time, like psychiatric disorder, psychosis, psychotic patient, or anxiety, these kind of things. Substance use like opioid, alcohols, or other medical conditions like painful condition. Okay, so this can be one of the reason for the insomnia. So this is called as insomnia with comorbidity, morbidity. And then what is the remedy? Remedy is to overcome the pain, to treat the psychiatric disorder, remove the substance use. So insomnia can be treated. This is another one, not going into detail, called as obstructive sleep apnea. Obstructive sleep apnea. Apnea mean no respiration. When the respiration stops respiration. During the sleep, respiration stops. Why it stops? Because there is some obstruction. So that means for a very short period of time, breathing stops. Short period of time when the person is in the sleep. So this kind of, when a person wants to go into the sleep, okay, so he goes into the sleep, then there is some obstruction, then he wakes up and wakes up because the breathing stops. Okay, so he wakes up, then he falls again, difficulty in sleeping. So these kind of the circle keep on repeating. So very disturbed sleep actually. There's a term called as narcolepsy. So we have seen certain drugs that can produce the side effect of narcolepsy. Any drug that comes in your mind which can produce narcolepsy as a side effect? We did one drug, one or two drugs. Anybody remember? We did in the restless leg syndrome, dopaminergic agonist. Okay, rupinerol, pramipexole. So those drugs can produce narcolepsy. There are some other drugs also which can produce the narcolepsy. So this can happen as such. Plus some drugs can produce narcolepsy. What is narcolepsy? Excessive daytime sleepiness. Attack of the sleepiness during the daytime. Okay, so this can be attack also. Sudden sleep during the daytime. Or there can be the catalepsy. Catalepsy means sudden muscle weakness. This is a very complex phenomenon. Actually, there are many things in this one, not single thing, many things. There can be the sleep paralysis, or just a state of a paralysis during the sleep, or sleep-related hallucination. So many things come under narcolepsy. Actually, parasomnia, parasomnia, and insomnia. What's the difference between these one? Parasomnia, there is a disruptive sleep disorder, disruption. So there, it can be any kind of a disruption. Again, a very wide topic. Anything can happen in the sleep, but it disrupts the sleep, like sleep terrors, sleepwalking, nightmares, anything, any unusual behavior during the sleep, which ultimately wakes the person, and he is finding difficulty in resuming sleep. So whenever there's a disruption in the sleep because of some abnormal thing which is happening in the night, not of its own. Sometimes a person can have awakening of its own without any reason. But when there is some problems, you can see this is the problem. Then it is a parasomnia and the sleep is disrupted. Then we did this topic in detail, restless leg syndrome, the urge to move legs during the night, the unpleasant sensations during the night. So how to assess the insomnia in the clinical setup? So this is the index: insomnia severity index, ISI. Okay, this is the index which is used to classify or to to note down how severe the insomnia is. And this is important instruction that you give to a patient, that you maintain a sleep diary. For how many time? For how many days? For 1 week. Maintain a sleep diary for week, in which you will note down all the things related to your sleep. At what time you are sleeping, at what time you are getting awake. These all kind of things are maintained in this sleep diary. Okay, so where he quantify the sleep performance. So sleep diary for 1 week is important thing. So now there is a very, very important role of non-pharmacological therapy in this sleep. Very, very important role. So there can be the cognitive behavioral therapy for the insomnia. Obviously, this will be given by the specialist. Okay. So this kind of the therapy is there, behavioral therapy. And obviously, this is the first line intervention that will be done at the by not by the patient himself, but by the healthcare professional. Then the thing which can be done at the level of the patient. Okay, this is not done by at the level of patient, it is done by the health practitioner. But even before that one, even before the cognitive behavior therapy is started, the person will be asked to do this kind of a thing, that is good sleep hygiene. And this good sleep hygiene stimulus control therapy is very effective in mild cases of insomnia. Okay, so this should be first, this should be tried first, number one, good sleep hygiene, because it at the personal level. Then then it can be followed for a long term benefit effect. Obviously not for the short term benefit. Okay, the person says I'm having problem for the 1 or 2 days. Okay, then obviously this is not a good thing, but just for 1 or 2 days, and you know this is going to disappear, then you can go for the non prescription drug. So but if you think the problem is consistent, something like that one, so you can give this kind of the therapy. And as I told, these interventions are very important. Pharmacological interventions are not useful, or you can say they are less useful without good sleep hygiene. So you have to maintain good sleep hygiene. So what is stimulus control therapy that I told? Good sleep hygiene, which includes stimulus control therapy actually. So this is a common thing that I'm telling. What is good sleep hygiene and stimulus control therapy? They are same thing actually. So avoid napping during the day. Obviously, if you are sleeping in the day, how you will sleep in the night? So this is a common sense thing, but this has to be told to a patient. This can be one of the big reasons. And this is again a very common problem. We start using our bedroom for our work. So if the bedroom is used for the work, so the kind of the feeling is not there that I have to sleep, because this kind of a, you can say, psychological thing should be there whenever he goes to the bed. So obviously one thing should come into the mind, that this is the place where I have to sleep. But now the stimulus is not there. Stimulus for the sleep is not there. Rather, there is stimulus for the work. So this is a very important instruction. If the person is having the problem, use bed only for your rest purposes, not for your work purposes. Go to bed only when you feel sleepy. Only go to bed only at that time. Otherwise, not. And maintain your cycle of sleeping and waking, particularly the wake time. Don't think for how much time I have slept. Always get up at the same time in the morning. This will help in maintaining the circadian sleep rhythm. So get up at the same time in the morning. You will say sleep at the same time in the night. That's okay, but It is also important to get up at the same time in the morning, which is very important. And another thing, in the bedroom, remove the light emitting devices. Any, anything, if you think this is the source from where the light is coming, remove that one. Now, this is another instruction that you will give to the patient. If the person is not able to sleep for 15 to 20 minutes, sometimes you can recommend get out of the bed. Otherwise, the person start feeling anxious, and because of anxiety, the person is not sleeping. Okay, so this is one thing that you can recommend. This is also common thing that everybody knows actually. Avoid watching television and mobile. There are some other things actually, like you can say to a patient, do not have a clock in front of you. Okay, because as if you are watching to the clock and it is in front of you, then obviously the time will be in your mind that this much time has taken and I'm not sleeping. This will create a problem. One another thing that can be done is that I have not written here, but this is simple thing that can be told to a person, that try not to sleep. This seems paradoxical that I am saying, okay, but this is effective if you think. Now, what you will say? You say to a person that think that you try not to sleep, but what to do? Try to be try to wake. Actually, try not to sleep. Actually, you can say try not to sleep. Try person at 11, 10 o'clock that you don't sleep. Okay, so when this kind of a feeling comes in the mind that I don't have to do these things, so obviously that thing will happen. He will try to, as he trying to sleep, he's not getting the sleep. Just keep him that just try not to sleep. Then obviously sleep can come. So this is a paradoxical thing that can happen. Oh, some other points related to the sleep hygiene education, some other points. So these are the things that can has to be done, but some other things like ask the what is your schedule actually, what kind of the things you are taking before sleep, these kind of things. So you will say I'm taking the before sleep I take caffeine, uh, I take a cup of coffee, or I take the alcohol before the sleep, or I'm taking heavy food. So these should be avoided because these are stimulants. So they should be, if the person is obviously insomnia, obviously you have to say avoid these food at least 4 to 6 hours before bedtime. Okay, so you see what is your time of sleep, accordingly adjust 4 to 6 hours, and overall minimize the total daily intake of caffeine and stimulant overall also. And again, some cigarette smokers, they say I take a cigarette before during the bedtime, and whenever I awake during the night because I feel anxious, so I take cigarette. So obviously that is also producing the stimulus. This is stimulation. So this has to be avoided. Person ask the person to do exercise regularly. This is important thing because when he will do the exercise, the things start getting normal. But it is important not to do exercise within 2 hours of bedtime. Before the sleep it should not be done at least 2 hours. This is important. Yeah, before bed, have a light snack with the warm milk and some food which are rich in tryptophan. I told tryptophan is important amino acid, like banana or some food which uh, inhibit the degradation of tryptophan. Okay, so take those kind of foods. This is again a important thing that you can tell: sleep restriction. So that means, let's say your normal sleep is for 6 hours or 8 hours, let's say. So try ask the person not to sleep for 8 hours, but ask to sleep for 7 hours, 40 minutes, or 50 minutes. So, or depending upon the person, to just reduce the sleep period. So mild, not excessive, intentionally sleep deprivation promotes better sleep. So you try to reduce the sleep time intentionally. It will promote the sleep for the next days. These kind of things. Sleep restriction. These are again sleep hygienic educations. Then these are all come under the category of non-pharmacological, and you can see these kind of things. If you are not following these kind of things, so obviously for how many days the drugs will work. So these are important points. So you have to ask the patient every time he comes whether you are following these sleep hygienic points or not. Okay, so consult these things regularly. Pharmacological therapy. So when to start the drug therapy? When you want to give drugs. Now it depends upon what is the daytime impairment. That is the actually the driving force for the intervention, not the night uh, insomnia. The point is, because of night insomnia, the person is having daytime impairment, which is the major goal. So treatment is basically focused so that daytime functioning is restored. So obviously you don't want to give such a hypnotic so that his night is okay. So he's asleep during the night, but during the next day he's again feeling sleepy. There's a hangover. So you don't want to give that kind of the medication because your focus is not on the night. Obviously, it is on the night also. It is not there. But what I want to say is the major focus is on the daytime functioning. That is more important. So that has to be taken into your mind when you are giving the drug. So how the person will do during the daytime. There should be lesser side effects of your drug during the daytime. So there are some non-prescription drugs like diphenhydramine, natural products, okay, like valerian, melatonin, low dose tryptophan. I will discuss these one by one. Then there are some prescription drugs also. Prescription drugs are schedule 1 drug. Okay. So these non-prescription can be schedule 2, 3, 4. Prescription drug, major drug is the benzodiazepines. Then benzodiazepine